Bom dia. Hoy no voy no voy a speak in Portuguese, but I promise maybe next time I'll try to learn a little bit more, and then maybe I'll do a little bit of talking in Portuguese. But I'm very happy to be here. We have explored Rio de Janeiro a few days ago. Now we are in Sao Paulo, and I have a very great time meeting with a lot of embryologists and clinicians here in Sao Paulo, and I'm so impressed the amount of technology and laboratory sophistication that I have seen so far. Our goal here in Brazil is to help local clinics improve their clinical outcome. We are coming with a lot of data that we have accumulated through the years, and we have also a lot of have improved the technology of sequencing to a point where we can contribute with our expertise and help clinics improve their outcome. We're not just coming as a reproductive genetics company, but also we are bringing with us embryologists that have 10 to 20 years of experience in the field. Today, I am going to talk about this particular angle, which is how do we intend to improve clinical outcome through our partnership with the clinics here in Brazil. So as you see, there is three components to improving outcome. You have the patient aspect, which is understanding the limitation that you are dealing with in the patient. Some patients have endometriosis, some of them have PCOS. The stimulation protocol is not always the same. It varies from patient to patient. And then you have patients that are coming with genetic factors that can impact their outcome down the road. Some of these factors can be translocations. You know that patients with translocations have a high rate of imbalance embryos that if you don't do genetic testing on them and do genetic testing on the embryos, your ability to have an improved outcome, it will be limited. We are also exploring with our data, comparing different stimulation protocol and then comparing the quality of the embryos, the timing of the transfer, etc. On the laboratory side, we are looking at every aspect that an IVF lab has, including the quality of the embryos, the day of the biopsy, the vitrification technique, the tubing techniques, and we are doing this through a portal system that takes all that data in one side and then can do data mining and interpretation so that you can understand where your limitation is. For example, if you have a laboratory with 10 embryologists, our portal can compare all of them and then can tell you, okay, this embryologist needs more help because they have more high rate of mosaicism or high rate of no calls, etc. So that's what the portal is designed for. So to start with, I'm going to talk a little bit about the portal. So the portal will allow you to submit your test requisition online. So it's an online system. You can submit your biopsy online. So as you know, in the clinic, you have the coordinators, the nurses. Those are the ones that enter the patients. Then the embryologist can come later to the same portal. You will enter the biopsy information. In the biopsy information, we capture a lot of information that after will turn into some sort of data. And then the patient is also connected to the same portal. So once you enter the test requisition, you enter the email of the patient can get a notification, they can create a portal, they can submit the signature of the consent online, they can see the results when you allow them to see it, they can look at the progress of the reports, they can request genetic counseling online. It's all incorporated in one platform. That's what we have been working in the last 6 years. So the laboratory that we are, the components in this puzzle is the automation. So wherever the clinic enters on the portal, it gets transferred into our side of the laboratory and directly into the test results. So we don't have errors, inscription errors. We don't have errors because whatever you enter, what populates the test results. and that minimize the type of errors in the date of birth, the name spelling, etc. We have also integration with an AMR system. I know in Brazil you have about 2-3 AMR system, electronic medical record. That's the system that you are using to enter your patient, and you add all the information. We have integration, so our data, our results get pushed through a portal-to-portal communication, and it goes straight to the patient chart. So you don't have to enter anything manually. It's all incorporated. So we have done a few AMR integration in a way that we facilitate you to order a test without having to go to our portal and enter all that information on the portal. You just click, I want a test with Progenesis, and we capture the data automatically. And then we send the results to the portal through an API integration. Data intelligence is one of the biggest components we have in this portal because it knows the differences between day 5 and day 6, between age groups. It looks at different embryologists. It does a smart work of comparing all that data to give you the best results possible. Obviously, we have ability to do this on a mobile form. The patient can use a mobile to do all all the functions they need. The laboratory can use a mobile or can use a tablet or a computer. One of the aspects of improving outcome is you have to understand what the patient needs. Patients' needs are so complex sometimes. You have to know, for example, when you have patients, how long it takes to patients to get pregnant. A lot of clinics don't measure that, right? And so when you are trying to grow your practice, you really don't know what to improve. Is it the time to pregnancy? That is important. So if you are not using genetic testing, your implantation rates and your pregnancy rates are going to be lower, right? So you have to do a second cycle and maybe a third cycle. So from a patient experience, it's very difficult. It's much better to get a patient pregnant in first try than try to get them pregnant in the second or third try. And so that's what we are focusing on. So our portal can measure the time to pregnancy. It can measure the patient success experience, whether they're happy or unhappy. And you can compare your clinic outcome with all the clinics here in Brazil or with the clinics in the United States. So you have the ability to compare to say, okay, how do we do? Are we doing well compared to other clinics? Our analytics have a lot of things to measure. You can measure the euploidy rate. You can, the euploidy rate tells you how many embryos are euploid given the age of the patients and given, euploid versus euploid. What is your rate of mosaicism? What is your rate of low DNA? And I'm going to get into that a little later. And then you have transfer rate. Transfer rate is what is the probability of having at least one embryo to transfer given the age of the patient and how many blasts you have. So if you have a patient that is 42 years old, they're coming to you as a clinic thinking they're going to have a transfer. They think they paid for an IVF treatment and they're going to have a transfer and they're going to have a baby. The reality is very different, right? We know that. We know that 42 years old has maybe 20% chance of having an embryo transfer. Our data will give you that. It will show you based on the age of the patient and based on how many blasts they have, what is the likelihood of that patient having a transfer. So if you have a consultation with the patient, you're telling them, we're going to help you. You have 20% chance of having a transfer. It's much better than having go through all the process and get frustrated later on and get unhappy. So you give them a clear expectation of what they're going to see up front. And that creates loyalty with the patient. Patient will know that you are upfront with them, that you're trying to help them. But the reality is that not every patient is going to have a transfer. And so we have other things like the clinical outcome. here, and so forth. We can go into this a little later into more details. So part of the improvements in our portal is that you want to have an implantation rate that as high as possible. You want to have a high clinical pregnancy. Some of our laboratories have 80% implantation rate. Some other laboratories may have 50%. Why is it very different when you compare to IVF clinics? And pregnancy rates, it could be higher than 70% in some situation, but there are other clinics that have low pregnancy rates. With progenesis, we have accomplished a miscarriage rate 5 to 10%. And so our mosaicism rate is about 2%, and I'm going to get into that later, and then I'm going to talk about the other components of the testing. Mosaicism has been the challenge for every clinic. 10 years ago, nobody was talking about mosaicism, and suddenly everybody is talking about mosaicism. The patients don't know what to do with it. Do you need to transfer or not transfer? The clinicians are confused because they don't know if that mosaicism, sometimes you transfer a mosaicism, get implanted, sometimes it doesn't. So it's a very big, very difficult problem to solve. What we have done through the years is do research on mosaicism to try to understand what are the limitations and how can we give a better information to patients to help them navigate through this exercise. So in this presentation, I'm going to talk about how often, whether mosaicism is real, how often it happens in nature, and then what are the criteria that play into the rate of mosaicism. Is it technology? Is it the embryologist? Is it the genetic lab? And then how do we do counsel with patients regarding mosaicism? The first question is mosaicism real? The answer is yes, because we know it because there are newborns. For example, trisomy 21, 5%, so one in every 5 babies that have trisomy 21 is mosaic. So yeah, they do happen in nature. We have situations where patients have miscarriages with mosaic embryos, and the Turner syndrome, also there are situations where you can have some mosaicism. But the reality is, when we look at thousands of transfers, we only see a few of them that have mosaicism, right? So we have analyzed 135,000 embryos and thousands of transfers, and I can count, maybe we have found 3 or 4 mosaic cases. So why are we reporting mosaicism so high? Why we are not finding mosaicism in pregnancies? The answer is it's inflated. We are exaggerating the amount of mosaicism in reports. Why does it happen? I'll tell you a little bit more about it in the next few slides. So in our data, mosaicism is, in all laboratory combined, the US and other countries, mosaicism range between 2 to 25%. So you ask the question, why is it so variable? 2% is low, 25% is super high. Our mosaicism rate is 2%, about 2.5%. But the true rate of mosaicism we have found is 0.5%. And I'm going to go into that a little later to explain why we think it's so low. Those are studies that have transferred mosaic embryos with low mosaicism rate. The implantation rate and the pregnancy rate were very close to euploid embryos. And so you hear people saying there is self-correction, embryos are low mosaic, but then this self-corrects. There are some, the reality is we have noise. We have lots of noise in our data, and we report low mosaic as if they were truly mosaic, but the reality, it's a technical noise. So in this figure, I'm going to show you a little example to explain why mosaicism vary between labs. If you're using a linear platform, regardless of how good you are in genetic testing, just by using the platform itself, you have 6 to 25% mosaicism rates. And the difference between these two platforms is this has a very short reads, 36 base pairs. So when you're sequencing, your pieces of DNA is this small. Now remember, to do aneuploidy testing, you have to take those little pieces and you have to put them together, right? You have to find the ones that are similar, put them together so that you form approximately 2 million reads. And those 2 million reads are one data point, and you have hundreds of thousands of data points that you can use to call aneuploidy. The problem is that the analogy is, does anyone like to play puzzles here, to put puzzles together? So if I give you small puzzles and I ask you to assemble them, there are more chance of making mistakes if I give you bigger puzzles. It's easy to assemble. If I give you tiny puzzles, there are errors. Those errors get transcribed in a form of mosaic, because mosaicism is just an intermediate copy number. So if you have noise, whether that is in the data analysis or in the DNA amplification or in the quality of the biopsy, it translates at something between 2 copies, between 2 copies and 3 copies, or between 1 copy and 2 copies. And that intermediate copy number is what we call mosaicism. There is no genetic marker that measures mosaicism level. It's all computational analysis. It's all algorithms. So, if you're using Thermo Fisher, you have about 6%. We have taken Thermo Fisher and we have modified it so much to increase the length of sequences, going from 100 to 150, and increasing the number of reads, going from 100,000 to 250 or 300,000. And by that, and we remove certain calls that are inconclusive, because there is nothing wrong about saying, I don't know. You can say it. If you have a sample that is messy, you have all kind of patterns, you can say it's inconclusive. It's fine. If it's inconclusive, the clinic can decide if they wanted to rebiopsy and transfer. Not everybody likes to rebiopsy, but if you do rebiopsy, you get a better result than calling that a mosaic. Because mosaic, maybe the patient is not willing to even rebiopsy that. So, if we compare embryologists, we have 145 embryologists in our database, and the question is, if we just look at embryologists and you compare the rates, you get 0.5 to 5%. That's tenfold difference just by comparing embryologists. And that gives you an idea of how the impacts of how you're doing things can impact the final result. Now, the technology platform has an impact from 2% to 25%, that's a tenfold, and then the embryologist has an impact from 0.5 to 5, another 5, a tenfold difference, right? So before I translate transition to next slide, we ask the questions based on the embryologist's experience. What do we expect? Do we expect 0 or do we expect 5%? So how many thinks a great embryologist should have 0%? Raise your hand. 0%, a good embryologist? No one think is good? No? Okay, how about 5%? How many of you think that 5% is a good outcome for a good embryologist should have 5%? Raise your hand. Only one. Okay, so the reality is, if you are getting 0%, you are too aggressive with the biopsy. You're cutting too much. So you may be compromising the viability of the embryo. Because remember, you're going to take a chunk of the biopsy, send it to the lab, then you have to vitrify that embryo to store it, then you have to thaw the embryo, and then you do the transfer. There's a lot of stress a lot of manipulation. So you don't want to cut too much, right? So 0% is not good, right? If you are doing 5%, you're not taking enough. You're taking very little, you're too conservative, you're not getting good data in general. Most of our embryologists that are very knowledgeable about embryology are in the 2%. And 2%, you're taking enough. You're not going to get 100% good biopsies. Sometimes you may have 2, 3 in 100, but you're getting enough material, not too much, not too little. So it's a balance between how much you're taking and what is the accuracy of the test. This is a study done on miscarriages. It's 1,000 patients. The question is, when you look at natural conception, how many patients, what is the rate of mosaicism? So what they did here, they took CVS samples and they allowed them for short and long culture. And then they compared the data between the karyotyping on short and long culture, and they compare them. If there are differences, that's what they call mosaic. They found that 3.5% were mosaic. There is a little bit of noise there because when you grow the culture system is not natural environments. There must be some stress. Actually, 3% is an actual higher than what we would expect. It's probably less than 3.5. Most surprisingly, what is the main cause of miscarriage? The main cause of miscarriage is single trisomy. A single trisomy is about 65% or so. So that's the main cause of miscarriages. The monosomy is only 9%, 8-9%. So if you are transferring an embryo and you don't want to deal with miscarriages and that embryo is abnormal or mosaic, you should prefer or you should prioritize monosomies versus trisomies. Monosomies are safer choice because they don't miscarry that much. Then within the monosomies, you probably would want to go to avoid chromosome 13, then 18, 21, and 22, because those are syndromic. And you want to avoid chromosome 16 because it's the main cause of miscarriages in reproductive medicine. Another question, does mosaicism vary with age? If mosaicism is a sort of abnormality that we see in chromosomes, it should vary with age, right? It should increase with age because with age, the cell process, get a little older. The enzymes and the genes don't function the same way, and the chromosome separation gets a little bit faulty, and you have some non-disjunction events in cells that lead to the chromosome abnormality. The reality is, when we look at mosaicism and age, they don't correlate. And if they don't correlate, that means they're not real. So we looked at chromosome abnormality, frequency of abnormalities in our population of embryos. In this data, you have 135,000 embryos. It's a very large data set. And you can tell chromosome 15, 16, 21, and 22 are the most common. If you look at the study that I mentioned earlier, this miscarriage study, they have also found that chromosome 15, 16, 21, and 22 are very common, which means that the PGT data mimics natural conception. They are similar. When you look at mosaics, you don't see that distribution. And you don't see it, again, because there is a lot of noise in the data. So we have done rebiopsy of mosaic embryos. When we do rebiopsy them, our rate is 2.5. When you rebiopsy, 20% of those biopsies are confirmed mosaics, meaning 0.5% are mosaics, only 0.5%. So the other 0.5% are euploid and 1.5 are aneuploid. That is the distribution of retesting, rebiopsying mosaic embryos. When you look at clinical outcome, if you transfer these mosaic embryos, again, only 20% lead to pregnancy. So 20% lead to pregnancy, another 20% miscarriage, and the 60% no implantation. But again, we're talking about 0.5% only. So what we see in the aneuploidy results match the implantation rates. Implantation and pregnancy rates. So some of the data we are managing with our portal is the ability to not only give you euploidy rates, but you can compare your rates with day 5 and day 6. You will be surprised that day 5 and day 6 are very different when it comes to outcome. Here we show a patient under 35 years old. The euploidy rate is 67%, and on day 5 and on day 6 is much worse, which is 60%. So there are about 7% to 8% difference. In some other age groups, it can be up to 10%. So if you compare day 5, day 6, and day 7, there is a 8 to 10% between 5 and 6, and another 10% between 6 and 7. So if you have an embryo to transfer, and that embryo looks better on day 6 than another embryo on day 5, which one would you transfer? It's a difficult decision, right? Do you go with embryo grade, or do you go with the age of the embryo? The data will tell you what is the best choice to prioritize the age of the embryo or the embryo grade. Here I am showing you just based on day 5 and day 6 as an age. When you look at implantation rates, again, all age group combined, the implantation rates on day 5 is 78 among all our clinics. The day 6 is only 66%, and pregnancy rates 65 versus 49. So obviously you can see that if you are working with day 5 embryo, you have better rates. The reason is simple. If an embryo needs 6 days to get to the mature stage, it's struggling. There is a struggle there. There is not an embryo that grows quick enough. There must be some genetic defects that is not measured with chromosome, maybe at gene level, maybe there is some stress, maybe there is, there are a lot of factors, cellular factors that impact the embryo development. And so the other observation we see that biochemical is higher with day 6 and miscarriages. So an interesting observation would be mitochondria. So mitochondria is inherited in oocytes. A typical oocyte has 200,000 mitochondrial units. In the first 5 or 6 days of embryo development, the embryo does not make any mitochondria. It is made after implantation. So what happens in these first 6 days? The mitochondria is distributed across cells to provide a source of energy for cell division. So at day 1 you have a lot, day 2 you have less per cell, and it gets distributed. Every time you have cell division, the mitochondria is segregated. At the end, at day 5, you're going to have very little mitochondria. But if the embryo is struggling to divide, in day 5 you're going to have slightly higher mitochondria. That's what we use as a proxy for an embryo development. An embryo should have very little. If you have higher than what you expect, you should probably not transfer that embryo as a first priority. When we look at the outcome of embryos that have high content of mitochondria, we didn't see differences. And people will start to be skeptical, saying, okay, if mitochondria is not that good of a marker, because when you transfer embryos with low mitochondria or high mitochondria, you don't see differences. And that's what we see here. You don't see differences. They behave the same way whether they have low or high mitochondria. But if you do just day 5, day 6 itself, there is differences. But if you take day 5 with low mitochondria, and then you put day 6 with high mitochondria, meaning that you put the best of the best. You put day 5, and you put low mitochondria to improve, and then you put day 6, and then you put the highest mitochondria, the poorest score, then this difference become bigger, because that's how you could measure it. So the reason I am putting this slide is when you have data, you don't really know what's the impact till you start running all kind of analysis and clustering the data. That's where you get value. And if you just look at it at a front face data, it's sometimes hard to get conclusions from that. So the other question is embryo grade. Does embryo grade matter when you do a transfer? The answer is yes. AA grade embryos have more implantation rates and more pregnancy rates than CC. You can see a very good correlation. Also, the biochemical C grades have a higher, miscarriage rate, biochemical rates than AA. And finally, if you don't do testing, if you don't do genetic testing, what is the likelihood of having a euploid embryo just based on the grade? Let's say you take an AA grade and you don't do PGTA, right? You have 60%, this is the rates, euploid, aneuploid, you have 60% chance of having a euploid embryo just by taking A grade, right? Now, that 60%, when you do implantation, it becomes 45%, right? And then and pregnancy rate, it becomes 30 to 35%. So if you don't do genetic testing, you start with 60, then 40, then 30. That's why genetic testing is so important, because when you start, you don't start with 60, you're starting with 80, then you go down to 70, and hopefully pregnancy rate will be 65 or close to 70%. That's the difference. Everybody that is skeptical about PGTA, show them the data without PGTA and with PGTA with the same conditions, and that's how you could have a more compelling argument. I think with this, I'm close to finalize my presentation. Just want to say that our approach in genetics is a combination of data intelligence. We use a lot of data. We are trying to incorporate time-lapse information so that when you are trying to transfer an embryo, you don't just look at aneuploidy, you're also looking at how the embryo behave in real time. So if we can combine these two data into one report where you see the ploidy, but also you see the score of the embryo based on time-lapse, then you're gonna have a much better perspective, much better information to do the transfer. Spin media is there. There is about 80% correlation. I don't think it's ready yet for prime time, but metabolic profiling is something that we are very interested in. We are interested in looking at the embryo, not just for chromosome composition. We want to know how to behave metabolically speaking. So an embryo is given sugar. They have to metabolize that sugar down through the TCA cycle. What is the rate of metabolism? What's the usage of amino acid? How many hormones are secreted by that? What type of hormones? In a study that was published a few years ago, they found that embryos at day 5, they have grown the embryo till day 12. Because in the United States, you cannot grow the embryo beyond 12 days for research. So they grow it till 12 days, and they start watching what happens. The embryo secretes interleukins and other hormones because it is preparing the environment, the endometrial environments for invasion. So there are a lot of things that are happening on the embryo that is promoting invasion. So if we can get that information with the metabolic profiling, you're going to get a completely different perspective of what that embryo is. You're not just looking at chromosome, but you're looking at activity. And that's what we are intending to do, find a more multi-combinatorial approach to choose the best embryo possible for implantation. To finalize this presentation, this is what your data would look like. You should be able to look at your clinic, compare your clinic across Brazil. You can also compare it to all the United States, and you can do all that data analysis to get the best results possible. And with this, I'm coming to the end of the presentation. We have a few minutes, about 10 to 20 minutes, for any questions that you guys may have. Dr. Fernanda Pacheco and myself are here. She is a reproductive endocrinologist, specialized in fertility treatment, and I am a geneticist, so we can take any questions. Thank you so much. Thank you.